2 years ago. I think you guys on the 2-year cycle. Some of you guys have heard it. I have slightly tweaked it, but not much. But we'll try and go through the didactic part of it as quickly as possible. If you've got questions, you must either type them if you can, or put up your hand or something. And I'd rather we make it interactive than me just talk to a screen. And if I see folks with TVs reflecting on their glasses in the pictures there, I'm going to pick on you. Okay. Are there guys still joining here? Looks like everyone is here. Tell me, do we have guys outside of UCT listening? Okay, let's go for it. So distal radius fractures, maybe 15 years ago were actually quite simple to deal with. You didn't have many options, and you also didn't have a plethora of literature trying to confuse you. I think what has changed is that there's a lot of pressure on us as clinicians, surgeons, to be responsible in the decisions that we make, in terms of what's in the patient's best interests and what's in our best interests as surgeons. I think that if you see the statement here by Carozella, this is in 1988 already. So this is not a new concept, but I think it's probably the most valid statement that sums up distal radius fractures, is that it doesn't help chasing a pretty X-ray if you have a bad clinical outcome. And what we're starting to see is that you don't need a pretty X-ray for a good outcome. But there are a lot of caveats to that. And I think the message that I'm trying to give to you guys tonight is to be cautious of applying a cookbook recipe to your patients in trying to decide on how to manage distal radius fractures. Why is it not advancing now? Sorry. Let's see if I can use this. There we go. Okay, so we all know he is not going to talk too much about him. Probably the founder of the distal radius fracture, but ultimately it actually only describes one very specific fracture. So broadly speaking, two groups. We've got the largely younger patients, high energy mechanisms, often males, by virtue of the fact that it's doing stupid things. It's riding motorbikes too fast, mountain biking, lots of occupational injuries, high energy. And then you've got a second group of largely elderly patients with a more low energy mechanism. They're often female by virtue of the fact of their osteoporosis. Oops, now it is moving. It's trips and falls and things, and they're under the insufficiency fracture patterns. So essentially what this gives you is a very diverse group of injuries, all thrown in under the label of a distal radius fracture. And this is just a collection of various examples. And you can immediately start to appreciate that to just apply one set of principles to these huge, vastly differing injuries inevitably will lead to under-treatment in some and over-treatment in others. So to go back to, this is Mike Solomon's favorite question. For the seniors, I'm going to get pinned. I don't know if he still attends the Monday morning TUTS, the trauma meetings, but he loves asking this question. I mean, why do we even bother treating fractures? To make it look pretty and straight? Do we want to prevent it from healing skew? Do we want to prevent it from not healing? Do we want to minimize long-term complications? Or ultimately, do we want to try and restore the patient to a normal level of functioning as quickly and comfortably as possible? There's probably a bit of all of that. I'm not going to go through the whole lot of x-rays. I've just got a couple of points that I want to highlight when looking at x-ray patterns. On the true lateral, your lunate should be collinear. The curvature of the proximal edge of the lunate and the lunate fossa and the distal radius. if you look at that line, the mid-axial line passing down the radius and the true lateral should be cutting through roughly through the middle of the capitate to have it all collinear. And the other important aspect is this teardrop angle, which represents the volar lip and support of the entire carpus. And if you lose that structural support, it's like the edge of the cliff falling away, and then you falling down with the embankment. The teardrop angle should be somewhere around 70 degrees. This is just an AP. This is another underappreciated aspect of an AP X-ray. If you look at that line, I want to just I can find a pointer here somewhere. Let me just see if I can. Sorry, what is this thing now? Hang on, laser pointer. Let me just try this thing. So there we go. I can point. So this line here in red corresponds with the dorsal lip on the lateral there that I'm showing the laser pointer. Okay, you can appreciate the overhang because this line represents a cortical density, which represents that tangential view there. Okay, so there's substantial overhang, but in this dorsal ridge here. And likewise, the volar teardrop out here, why is it not advancing? Let's see, there we go. That is the volar teardrop, and that corresponds to the teardrop over there. And both of them project well out over the lunate and the scaphoid. And that's why sometimes when you place hardware, particularly dorsally, right up on the ridge to form a buttress function, it looks like you put it into the joint. And why it's so critically important to assess your X-rays intraoperatively to ensure that you haven't put any screws in the joint. Because both the radiologist and your colleagues will try and convince you that you did stick it in the joint. But if you visualize it directly and you appreciate what a radiological projection shows, then you know that it won't be in the joint. Okay. Someone else is waiting here. How do I? I've lost my. Let's get rid of this. Someone's trying to get in, but I don't know how to get my. Oh, there is he in. Someone's let him in. Right. Okay. So how do we decide on appropriate course of management when we sorry, I'm just trying to get this guy admitted to the meeting, but I can't seem to click on his thing. Just bear with me 1 second. I just need to get rid of my pointer. There we go. Okay. Sorry. Okay, so how do we decide on management when we're confronted with a distal radius fracture? We've got to consider 3 aspects. We've got to look at our patient factors, our fracture characteristics, and I've now included a 3rd factor, which is becoming more and more important, and that's the surgeon factors. You have to consider your own experience or expertise. You have to consider the resources available to you, and you have to consider the cost implications of your decisions. And this aspect here is becoming one of the biggest aspects of the algorithm, as we are now practicing in a cost-constrained environment. We're being pushed hard by the trade to spend lots of money putting their pretty plates in, and the literature is saying that it doesn't necessarily help. At the same time, we want to earn money, and we make more money from putting metal in than we do from putting casts on. So it is important to consider this aspect in your decision-making algorithm. The other component that comes into this is, of course, the challenges in the public environment versus what's available in the private environment. And you guys will all at some point be involved in both. And there can be remarkable differences or theoretical differences in the two environments. Okay. So the fracture characteristics, we know this basically. It's broken down into displacement, instability, and soft tissue envelope. So what is displacement? Displacement is essentially unacceptable alignment. So either you can't reduce it adequately or you can't keep it reduced adequately. Okay. Instability is the inability to keep it in the place you want it for long enough so that the bone can heal on its own. Remember that wires, plates, pop, they don't make a bone heal. The bone has to heal itself. All of those things do is they hold it in the position you want it to be in until it heals itself. And then the other component that mustn't be underestimated is the soft tissue envelope. Obviously open fractures, but other things might influence it as well, like concomitant nerve injuries, tendon injuries, that sort of thing. Okay, so that's a critical component to consider as well. We know these figures. I'm not going to go through them too carefully. Extra-articular displacement, the three-dimensional shortening, radial tilt, dorsal tilt, axial short, and then rotation. One of the things I just want to highlight that people underestimate is the effect of translation. So radial translation of the distal fragment with a change in the distal radial ulnar joint alignment can have a significant impact, particularly on drudge stability. So 2 mils of radial translation can create relative drudge instability that may become symptomatic. So it's an underestimated, and it doesn't appear in any of these algorithms or numbers or anything, but it's quite an important consideration, is to make sure that you don't translate, because very often the distal radius fracture is radially translated with some element of supination, particularly if it's a fall on the outstretched hand. Intra-articular displacement, what you get largely predictable patterns of fracture lines, and that's because of areas of cortical consolidation, and Bain has done lots of work with micro CTs, and he's actually demonstrated how the metaphyseal structure is strengthened along these cortical ridges, which actually produce largely predictable patterns, 2-part, 3-part, 4-part. And even though it might look like an absolute mess, there are still what they call constant fragments that typically appear. We all know Jesse Jupiter's article where he made this big statements about more than 2 mil steps and gaps cause arthritis. He then revisited his own work when he did a long-term examination of the very same patients that were used in the first study, and found that his conclusions were all wrong, and he retracted his paper because his patients didn't actually have arthritis, even though he thought that they were struggling. Sorry, they didn't have bad outcomes. Some of them developed mild arthritis, but it didn't correlate at all with their clinical function, which is it's difficult to know how to interpret that, because instinctively we are concerned about steps more than gaps, but steps in the articular surface area. But I think it's largely got to do with the fact that the distal radius is not an end loading joint like a lower limb. Peter, it looks like you need to put it to bed. It's the distal radius is not a gravity loading articular surface like the knee or the ankle. I think that's got something to do with why it's more forgiving in terms of gaps and steps. But that doesn't mean it gives you a license to ignore what is gross displacement in the intra-articular environment. These are just some of the predictors of instability, because of course, you know, we need guidelines on how to decide when we consider something unstable. I like LaFontaine's criteria. I think they do correlate reasonably well. I think the associated ulnar fracture, the styloid, I think is probably irrelevant. But of all of those, age has actually been shown to be the most important independent risk factor for instability. Dorsal comminution, people have tried to describe all over the place. It's not really possible. I think volar comminution is actually more relevant than dorsal comminution, because an intact volar cortex, particularly if you can hitch it, in other words, restore it, it becomes much more stable, particularly in the axial alignment, than if you've got a comminuted volar cortex. In the absence of a volar restraint, you can't then perform a closed reduction and hinge it back on. It will tend to compress down. So this is our premise of how we go about deciding that something needs an operation. It's built on the principle that something that's unstable will then displace. And we think that displacement leads to malunion, and malunion in the short term will cause a stiff and painful wrist. In the long term, predisposes the patient to arthritis, all of which sums up a poor functional outcome. And then we pat ourselves on the back and say, well, we want to avoid that. And we go all the way back up to the top and say, we want to prevent all of this. Therefore, we must operate. But this is where this logic flow has been challenged with the recent literature, particularly in the elderly patient over 65. Our assumptions have been shown to be wrong about instability and displacement and malunion causing pain and stiffness and arthritis and poor outcomes. It breaks down here. We know that this part is right. We're not challenging that. We know that fractures that are unstable tend to displace and then will heal in a displaced pattern. That's not up for debate. So Lafontaine's criteria, they're all valid criteria. The problem is that the literature is showing us that in elderly patients particularly, the radiological appearance of the malunion does not translate necessarily into these short and long-term functional outcomes. But we've got to qualify that statement because those are massive statements to make. Okay, so patient factors. We've spoken already about the two groups. But so the young group, one hand, you've got good quality bone, they heal well in their favor, but you've also got the fact that they are young and they're going to put a lot of load through that wrist and they're going to do it for a long time, which you could argue means that they might be more sensitive to developing arthritis if they have an injury at a younger age, because they need that wrist for longer and they're going to make it work harder. So perhaps you should be less tolerant of malunion in the younger patient. The older patient, they tend to be lower energy fractures, we know that, but they don't put necessarily the same demands to the wrist. But you got to be careful making those statements. We know they've got poor bone quality. We know they heal a little bit slower, but those are not necessarily on their own factors to consider in when you decide. So this busy algorithm, I actually think, is a very useful one that just lays out something on paper of how to manage a distal radius fracture. And I think it's a reasonable one if you challenged in an exam to provide some numbers in that, and there will certainly be consultants that will push you hard and they'll show you an x-ray in the OSCEs and say, what are you going to do? You'll need some numbers to back yourself up. But you'll notice that this algorithm is purely considering fracture characteristics. It does not consider anything to do with patient characteristics or surgeon characteristics. So this just assumes 1/3 of the aspects. And this is where you have to be careful how you weight these various considerations. If you apply this algorithm to the incorrect patient, you might have an inferior outcome or non-superior outcome. Let's put it that way. Okay. Right, costs, lots of different versions. Surgical options. I'll just say one or two things pertinent to surgery. X-fixes for distal radius fractures, in my mind, should be reserved for the short-term management of the open complex fracture. With the modern plating systems of ORIF, I personally don't believe that we should be X-fixing distal radius fractures anymore, other than for temporary reasons. If you do want to do it, and some of the older surgeons still like it, you must combine it with some form of focal pinning so that you can take the distraction off once it's stable. Otherwise, you increased in stiffness and CRPS. The second image is a dorsal spanning plate, which functions as an internal X-fix. And in the patient who you would consider too badly comminuted and would be considering an X-fix, my first choice would actually be to put an internal spanning plate as an internal X-fix, rather than actually putting an X-fix on. ORIF with a standard volar distal radius locking plate becomes the workhorse, but more increasingly fragment-specific fixation is becoming more popular, particularly as trade pushes these sets, because they can charge for 2 plates rather than 1 and essentially double their income. So that becomes a very important consideration when you're going to choose fragment-specific fixation. You can easily hit 50,000 Rand of hardware if you go for fragment-specific fixation in the private market, which is a scary number if you think about it. They will sell you a hip replacement for 21,000, but you can fix a distal radius for 50. This is, I think, one of the most brilliant studies and most revealing graphs that you're going to see. In a nutshell, what it is, the dotted line is the DASH score. In other words, how the patients did at 1 year. This is a massive study, 3,688 patients. The blue line, this massive Everest peak here, is the surge of distal radius fractures being managed by volar locking plates. Now, the interesting thing is, when it kicked off, there wasn't a massive reduction in the other forms of surgery. There was a little bit, if you look at X-fix dropped off, but what it did happen was the patients that were previously being managed by non-surgical means suddenly started being operated on. Okay, and if you look at this dash line around 2005 here, can you see that the dash score went up at the initiation of the locking plates? It didn't go down. It took a year and a bit to start coming down, and only hit the same level that it was in 2004 in 2008. So it took them 3 years to figure out how not to use a locking plate, a volar locking plate, before the results became acceptable. And you'll notice that they're certainly not better. They're the same. And there's a good lesson in that. And I think trade is heavily responsible for this graph. But we as surgeons ultimately are the ones that put these plates in. So we can't blame trade for trying to tell us that they're brilliant. This initial surge in the dash score was largely related to screws that were too long dorsally, causing tendon ruptures, and too bulky and badly placed on the volar aspect, and also causing tendon ruptures, median nerve, carpal tunnel problems, and the rest of it. Okay. So now we're presented with 2 scenarios. Are we going to operate on the patient? We're going to put them in a POP. So on the one hand, you could argue, why don't we just fix everyone? We know that we get good outcomes from ORIF. Patients don't need POP. We know that it produces consistently good X-rays and consistently good results. And it's good for the surgeon. We can make money. On the other side, we've got literature telling us that operating is no better than putting a cast on. So why should we bother to fix anyone? You know, the NHS is trying to convince us that orthopedic surgeons are not needed and operating is not required. They're putting out literature all over the place. Proximal humeruses mustn't be fixed. Now they're telling us scaphoids mustn't be fixed. Basically, they're trying to put their surgeons out of business. So that in itself is an important consideration when you read their literature. They have an agenda. They're trying to save money at all costs. And that doesn't necessarily mean that they've got the patient's best interests at heart. They are essentially just trying to save money, but they are presenting quite a convincing argument that we're going to, with high quality research, that we cannot ignore. Briefly, the evidence. These are some older studies, but this is where it all kicked off. Aurora started to show in his group no difference in outcome at 4 years between ORIF and non-operative treatment. This one, 2011, showed initial significant differences in the ORIF group, but it's always in the first couple of months, and it tails off and it becomes equal at a year. But the one thing that's consistent is that grip strength tends to be better in the ORIF group, and that's something that's been shown in multiple things, and it's something to bear in mind. This study, long-term study, 15 years, showed no correlation between the reduction, the quality of the radiological appearance, and the development of arthritis. So back to Jesse Jupiter's study, it was good that he retracted it because he saw the same thing, in spite of what he said in his own study. Okay. They looked hard at what, how do you predict whether you're going to have a happy patient? And they summed it up, all these studies, by saying that grip strength was one of the things that had the biggest role to play in subjective assessment by the patients. The patients that had good grip strength tended to be happy patients. And who gets better grip strength? Well, it's the ORIF group. But the problem is that how much grip strength do you need to be happy? A young patient, you could argue, needs a lot more than an elderly patient who only needs to lift a cup of tea. So again, all of this literature is used and interpreted with the individual patient in mind. Okay. Same story here. Let's move on. This is just a comment on rehab. So, you know, for those that push physio hard, does it make a difference? Again, the physio group may be better in the first couple of weeks, but already by 6 months, no difference. Okay, but that was in an operated group. So is the benefit the plate, or is the benefit the physio? This graph was showing slightly accelerated recovery in the intensive physio group, but already by 6 months, no difference. PRWE, patient-reported risk evaluations. They look at pain and function. Don't really need to spend too much time on this, but these are all the patient-reported outcomes. So if we look at this and we now go back to our individual, with all this sort of deafening noise that says we shouldn't be operating on these patients, you know, how do we decide whether we're going to spend a lot of money and help the patient on the left, or we're going to put her in a cast, but we're going to help the patient on the right? And I chose these two pictures because of another concept of chronological versus physiological age. You know, our patient population might be aging, but in actual fact, they're all getting younger in terms of their demands that they are placing on themselves and they're placing on us as surgeons. And to automatically assume that because they're 70 or 75, that they're frail and elderly and just want to lift a cup of tea is making a dangerous assumption about your patient, and it might lead you to not address their needs or their help-seeking behavior, and that ultimately leads to an unsatisfied patient. Okay. So what is the literature telling us? I don't think we can argue too strongly against multiple high-level studies that elderly patients, we're talking over 65, 70, do not need anatomical reduction that we achieve with surgery. They can cope with less than perfect distal radius fractures, what we would consider to be almost malunions. They can certainly cope. Okay. But there's a big caveat to that, because what we think is coping might not be what the patient thinks coping is. And it's important to discuss it with the patient as an individual, what their expectations after their fracture is. Because if you tell a patient who has 20-degree dorsal tilt that she's going to be just fine, and you don't tell her that her wrist is going to look like that for the rest of her life, she might be very upset with you if she feels that sitting at La Perla on a Saturday with her friends and they tell her her wrist looks funny, in spite of the fact that she can get her Earl Grey tea to her lips just fine, she might consider that unacceptable because in her environment, she's not happy. Okay. And the literature doesn't address that aspect of it at all. Like I showed, that algorithm is purely designed to address the fracture characteristics and does not consider the patient in any of this. It also, and this is another very, very important point, it is heavily biased towards the elderly patients. There is nowhere near as much literature that looks at young patients with high energy injuries and their long-term outcomes. And certainly if one of you guys have me on the table or in the consulting room and you tell me you're not going to plate my distal radius because I've got 15 degrees of dorsal tilt and I'm too old, I'll plate my own distal radius, thank you. Okay. But it's important, again, to individualize your decision-making process rather than applying a cookbook recipe. So to sum up this didactic part of the lecture, I mean, distal radius fractures incredibly common, and they're becoming more common as our patients become elderly, and in this country, as our patient cohort is becoming even less responsible, if that's possible. Spoken about the two broad groups of patients, but don't try and shoehorn your patient sitting in front of you into one of these two broad groups and then decide based on which group they are as to how you're broadly going to manage them. Okay. You have to consider all aspects of them. You know, the patient factors, the fracture characteristics, and your own expectations and constraints. And then decide between all three how best to manage the individual patient. And I warn you guys again, and we're seeing it a lot, particularly with the trade pushing these fragment-specific plates onto patients. You know, the surgeons are not adequately familiar with the sets and the the techniques required to achieve outcomes with fragment-specific plating, and they're spending 50,000 Rand on a patient who could have had a better outcome with a POP. And that's where considering your own expertise and limitations is an important part of the algorithm. Okay. Because when you become consultants, you will be bombarded with the trade showing you shiny plates, hopefully not offering you anything for putting their shiny plates in, but at least they'll be showing you pink ones, green ones, blue ones, with nice screwdrivers, and you're going to want to just throw them in. But it might not be the best thing for your patient. Okay. So keep your patient central in this algorithm. Okay, so at this point, let's see, does anyone have any questions or anything? We've got a couple of x-rays that we can fly through. I see we've got a couple of minutes. We want to try and finish this at 9. Anyone want to ask anything at this point? Open forum.
Hi, Ian. It's Ashley. I just like to know, in terms of dorsal plating of distal radius fractures, you know, and
yeah,
when you need to put in a dorsal plate and when you think when you'll be able to hold sort of the dorsal fragments with screws through the distal-most volar plates. What is your sort of thinking? When do you choose to do dorsal plates?
Good question, Ashley. So maybe we must talk about this. Can you see this X-ray that's on the screen at the moment?
Yes.
So, so if you look at the lateral here, this patient has got a dorsally translated carpus. There is a ulnar dorsal fragment, very distal, and you've got a radial styloid fragment. Okay. Dorsal plating got a very bad name in the 20 odd years ago, with the first generation of plates that came out. They were bulky. They had sharp screw heads and caused quite a lot of tendon irritation. And as a result, patients, well, surgeons shied away from them. But from a mechanistic point of view, to dorsally buttress a dorsally displaced fracture is a very powerful mechanical construct and makes sense. So the concern is always about tendon irritation, but the modern plating systems are much more low profile. The arrival of locked plates on these dorsal plates has further added strength to the construct, where you can put a dorsal plate that is allowed to buttress right through down to the teardrop and hold it out to length. So they're quite powerful. So my threshold to go to dorsal plating is often influenced by the ability to capture the dorsal ulnar corner adequately from the volar side. And remember that you've always got to ask yourself the two questions. Can you reduce it? And once you've reduced it, how do you hold it? Okay. And if you can't reduce it adequately from the volar side, well, then you need to open dorsally. But just because you've opened dorsally, it doesn't necessarily mean you now have to plate dorsally. The important consideration when you're going to open volar and dorsal is remember that patients become much stiffer if you open both sides of the wrist. Okay. So often you can achieve, just with simple direct pressure on the thumb, you can actually achieve quite a good closed reduction of the dorsal ulnar corner and pin it from volar and capture it from volar, having reduced it. But sometimes your reduction is inadequate. So actually, to sum up and answer your question, when do I go dorsal? It's one, when I can't achieve an adequate reduction from volar, and two, I can't hold it adequately from volar. Now, obviously, in different hands and different plates, that might vary. So someone who's comfortable working with plates that go right over the watershed line, who's comfortable getting screws into dorsal ulnar corner from volar, might be able to manage most fracture patterns from volar. Someone who's less comfortable might feel that he wants to go dorsal as well. Okay. So again, there is no formal recipe, and you've got to consider those factors. Does that answer your question?
Yes, thanks. Just one more thing. The literature
Yeah.
seems to be unclear about whether you need to always remove the dorsal plates once it's healed, or whether you can sort of keep them there.
Easy
What do you
answer.
personally-
No metal, unless you're German, has to ever come out of a human. So, okay.
Okay.
Remember that taking metal out is as big an operation as putting it in, and comes with potential complications and things. Okay. The only metal that has to come out is KYs that are sticking out of the skin. But the modern dorsal plates definitely don't come out routinely. They might they might on occasion, if you're monitoring your patient. I think it's a good practice to always warn your patient in theory as part of your consent process. When you're going to put metal in, you will always warn a patient about the potential for it to have to come out because of tendon irritation. Okay. But ultimately, you're going to individualize it based on the patients. And your aim is to put the lowest profile plate in the best position to not irritate the tendons. Okay.
Okay, thank you.
Sure. Other questions, guys? Cindy?
No questions, thanks.
I hope you're reading your hands textbook there.
Oh my goodness, I read the whole Menon chapter 3, don't worry.
Oh, Okay.
Yeah.
Yeah.
Yes.
I
got a question.
Okay.
I noticed, Peter.
Hey, Peter, how's it?
I got a question. I know certain plates nowadays are probably a bit more expensive, but got that option to actually put like a frag lock compression screw from dorsally. I've never seen it, so actually never or seen actually when someone do it. But does it work? Like Acumed got that frag lock compression screw from dorsally.
Yeah, I think in theory it's a nice concept. Practically speaking, you've got to be very careful that you don't trap the tendons in that dorsal screw. And the other thing, I've tried it once or twice. It has the potential, because it's a lag, to be incredibly powerful and actually just drag that button straight through the very comminuted dorsal cortex. So if you're considering using that, you've actually got to have quite an intact dorsal cortex that is going to take load. And the problem with that is, by its very nature, any distal radius fracture that you're likely to be consider plating is probably got a comminuted dorsal cortex. So in the 2 odd times that I've used that thing, I've actually taken it out. I think I only left one in at the end of the operation, because it had just cheese wired into the metaphysis and added no value in its stability. And the other thing is, it's a mission to take out later on if you have to take it out for whatever reason, because now you've suddenly got something stuck on both sides.
Thanks.
Cool. Other questions? Okay, we'll spend the last couple of minutes just going through this. Ashley, so let me ask you quickly. So this on the screen, having looked at it, quickly tell me, how would you manage this patient?
I think I'd counsel her. Essentially, I tell her that she's elderly. Look, I try and find out 1 or 2 things about her baseline functioning and sort of physiological state and so on. But if she's a relatively low demand 70-year-old patient, I would suggest to her that essentially between conservative treatment and surgery, there's no functional difference for her. So surgery would basically give her a better cosmetic result, I think.
Okay, I think that's a reasonable approach. With the information that you have, remember, so she's a tourist. So the first thing is, no one's ever died from a displaced distal radius fracture. In other words, resist the temptation to say she has to be operated on tonight because she's getting on a plane tomorrow. Patients have died from the DVTs in the arms on the airplanes. So your discussion, you're right in saying you're going to counsel the patient, have a discussion and say to them, the first thing is, if they want to have it operated on back home in Spain, which I think most of us would appreciate, we want surgery in our own country with our own support mechanisms, it's perfectly acceptable. And in terms of the fracture configuration and displacement, on these x-rays, it doesn't look dramatically shortened. Yes, all the numbers are slightly changed. The one thing she does have, though, is on that lateral, so she's actually got significant supination. And that's one of the things when they fall off on an outstretched hand, is the distal fragment in the carpus supinates off the proximal metaphyseal area, which can create a bit of displacement. What did we do? So I just gave it a pull. She didn't want any surgery in South Africa. So I said, well, let's just put you into a dorsal block slab, and then you're welcome to travel home. And if you look here, you can see that she's at least a 3-part intra-articular. She's got a dorsal ulnar fragment, a volar teardrop fragment, and then that styloid fragment somewhere through there as well. It all comes out to length. Based on our knowledge of stability in that, this is quite an unstable fracture pattern, and it's likely to settle close back to where it was before I pulled it. But as you said, Ashley, it perhaps doesn't actually matter that it settles back too much. She might do fine. And unless we know that perhaps she's the Olympic pistol shooting champion and spends 8 hours a day, and she's left-hand dominant and needs an absolutely perfect functioning hand in the next 8 weeks for her competition, I think it would be reasonable to offer her conservative management, as long as you've counseled her, as you said. Okay. Right. Next up. Who else is here? Peter, just because I can see you on the screen. You there?
Yeah, Ian.
So this patient is actually currently an anesthetic registrar. I think you guys probably know her. From that lateral, I'm not sure why the one is sitting on top of the other one. That's possibly problematic for you to describe the injury, Peter. But just tell me what's going on in that lateral. Unfortunately, I can't move it now from inside the thing. Tell me what you can see from that lateral. No pressure.
So what I see is an intra-articular fracture dislocation where it appears the corpus is subluxed dorsally, severe significant dorsal comminution of the dorsal fragment. I don't know if volarly, I don't know if that volar cortex is still intact or if it's actually just that volar teardrop that's displaced with the actual corpus. I can't appreciate it. But it looks like a fracture dislocation with dorsal displacement.
Yeah, so it's a good observation. Can you see my pointer?
Yeah.
Drag around the screen.
Yes.
So that up there is the volar teardrop.
Yeah.
Very distal. Up there is the dorsal ulnar corner, and then tracing out here, this sitting up here is the radial styloid. That's all gone with the patient. So that's the x-rays post-op. So coming back to Peter's question, when do you go dorsal? Clearly, that's a highly unstable fracture pattern that's dorsally subluxed. And with a teardrop fragment of that sliver, there's no ways that you're going to hold that construct adequately from volar. Okay. And the powerful construct that you get from the dorsal buttress combined with a styloid and a 90-90 plating configuration is very effective. A couple of points to note here. See how few screws are put into these plates? You don't need millions of metaphyseal screws. Distal radius fractures never fail through the proximal screw constructs. If they're going to fail, there's a failure of the distal screw fixation or settling in or prolonged screws. So many of the plates are actually often too long, and you don't need to fill them. There is a tiny little threaded KY there, which I actually drilled through the teardrop to anchor that teardrop, because it almost represents an avulsion of the teardrop. It's like a wrist dislocation in a way, with large bony avulsion fragments from the various ligaments. That's 3 months later. She was a national level triathlete, a rock climbing fanatic. And I actually spoke to her the other day, and she says that she's been rock climbing all over, and her wrist is absolutely fine. So this is now, where are we? About 5 years later. So far, so good. Here's another female tourist, 76. Who else is on the screen here? You see, some of your X are hiding. I don't know why. Let's go further down the. Peter Venter, aka Groenies 2.
Yes, yeah.
Okay, tell me what you see there. Tell me how you're quickly going to manage it.
So I see 3 views of a distal radius. Doesn't say which one it is. So obviously want to know which handedness she is. But it looks like an extra-articular fracture. Not a lot of displacement, though, if you look on the lateral. In light of this, I mean, you give it a trial. Speaking with the patient, I mean, obviously, give her the options, but I would first try and reduce it and see what position I get and see if I can hold it. But seeing that it's a very big piece, Yeah, I'll try with a conservative treatment first.
Okay, so you'd give it a pull and a pop, huh?
Yeah.
Okay. Kim, what are your thoughts?
I think it's quite shortened. There does seem to be some volar comminution, and there's a lot of angulation or radial deviation, translation, should I say. And the drudge, I would be concerned because it might be displaced.
What do you think's going on that
or,
lateral?
So there's some volar displacement of the carpus as well.
The whole carp, so the carpus has gone a bit volar.
Carpus,
Remember that line?
and the teardrops is sitting.
What's the teardrop angle there?
It's shorter now.
So it's not going to buttress. It's not going to do a good volar. It's not going to act as a good volar buttress because it is tilted forward or tilted volarly.
Yeah. So
Impacted.
So if you look here, so can you see my pointer there, my arrow? That's an intra-articular split there. So that's intra-articular component, the dorsal ridge. This is all a large intra-articular fragment, but it's actually a large volar shear. It just happens to be the majority of the surface. But if you come back to here, look here. Up here is the dorsal ulnar corner there. And down here is the rest of the wrist. So there's dramatic shortening on this view. Okay.
This is the volar button.
Yeah. So it's a volar bottom. What do we know about volar bottom? Who said volar bottom?
Yeah, it's me, Ian, Mohammed.
Mohammed. Good.
Yes.
What do we know about volar bottoms?
Well, it's a shear vertical shear type. It's a very unstable fracture pattern.
Good.
That
So
needs a lot of.
Yeah. So there's, in all this sort of confusion, there's one fracture pattern that it's easy to tell the patient you must have an operation. It's the volar bottom. This happens to be a very big fragment. Often that teardrop is just a small bit, but what's confusing here in Peter's defense is there actually is quite good congruency on this lateral of the lunate and then the lunate fossa. It just happens to be that the remainder is a very small sliver of dorsal articular surface. But if you look on this lateral, you can see how short this carpus actually is. It's from there to there. Or probably, let's say, give it a variance of neutral. So it's from there to there. So this is the one fracture pattern that you cannot control in a cast. Remember, cast fix immobilization is very poor at controlling axial displacement. A fracture pattern will tend to settle back. It can control dorsal tilt well, and also trying to buttress volar tilt. You've got to be careful if you try and mold a cast and put pressure over the volar aspect. You can create carpal tunnel syndrome, and trying to massively extend the wrist further increases the carpal tunnel pressures in trying to drag this fragment out. Okay. So this is one that should have a plate. Okay, and they're actually fairly easy fractures to fix because you don't even need a locking plate because you've got the anti-glide plate or the buttress effect of the fixation. Okay.
I'd like to retract my statement, please.
All right, Peter. I know that you're dealing with 2-year-olds and Sufis at the moment.
Wires and pops.
Yeah. Okay. Right. Here we go. Peter, what do you think of this one?
Well, I think the C-point socialite is thrown in to mislead you. Well, this is well. Also, it's an elderly woman, slight osteopenia on the X-rays and the AP and the lateral. It is what I can see is 1-2 minimum of 3-point fracture with a ulnar styloid fracture as well. looking at the length is not too bad. Radial inclination maybe a bit off. The lateral slight dorsal tilt. It's not a true lateral. Seeing that this is an initial X-ray, and this might be the worst that it will look, it's unlikely that you will have any cosmetic deformity of this, even if conservative treatment doesn't work out completely. So in consultation with the patient, so taking into account her age, I would give it a pull and put it in a plaster, but that socialite thing scares me.
Yeah, no, look, I agree with you. One thing I actually didn't mention, I'm glad you mentioned it. This concept of giving it a pull. So and this is where you have to delve into the metadata of all these big studies, because some of them made all those findings following acceptable closed reduction of patients. Okay. In other words, they all got a pull and the x-rays looked pretty good after the pull. And they said that the later collapse and malunion are there. Whereas others accepted the fracture pattern with no pull and managed them as is. And one of the challenges, and I think government does it better, perhaps because we're more paternalistic in our approach, and we just tell someone, listen, you're getting morphine, dormicum in the side room, man up, and we're going to pull it. If you try that approach in private, you'll very quickly, your name will be scribbled on the back of a toilet door in C Point with a big skull and crossbones through it, saying, he hurts me. So in government, it's actually quite easy to just pull a patient. In private, it's a hell of an outing. If they happen to be in the casualty, you can do conscious sedation under the guise of the casualty. But if a patient comes to your rooms, you have to get authorization. You have to admit them to a hospital. They have to have an anesthetic. And by the time you have them in an operating room with an anesthetist present, the next step, logical step, is actually probably just to go and put a plate in. Not always, but it's a massive consideration to say that you're going to take a patient all the way to theatre just to pull them and put them in a pop. And certainly my approach of late has been to actually accept these patients and tell them that this is the position your wrist is going to be in, and put them in a pop or a thermoplastic splint in the rooms with the user from the therapist, and not even try and pull it. And for patients that I think need an improved position, the discussion goes strongly towards surgery. But now that is in the private realm. And in the government, and this is what I was talking about, surgeon side of things, cost constraints, resource constraints. In the government sector, it's easier to pull it and it's harder to plate it. So for the same fracture, you might end up managing two different ways in two different circumstances. But I agree with you, Peter. This C Point socialite, she loves La Perla, but she didn't want an op. So at 6 weeks, that's where she is. She started to tilt back a bit because we know that, as you said, those Lafontaine criteria, they said, yeah, it's unstable. It might move a bit more. Hasn't changed much. Perhaps it's just the view. And that's her at 1 year. She's certainly not normal, but she thinks I'm fantastic. She was able to continue drinking tea at La Perla, and my name's not on the back of a toilet door yet, as far as I know. But she's by no means fits the adequate reduction. She's like 20 degrees dorsally tilted. She's short, lost a radial inclination, but she's super happy. The only thing she asked me about was whether the bump on the ulnar side of her wrist is going to get any better, because it's been there for a while. And remember that all these patients, when they lose radial inclination and they have an element of translation, they get a big prominence on the ulnar side. And for some patients, that's the cosmetic issue that bothers them a lot. So you must discuss that aspect with them and warn them that that's how their wrist is going to look. Okay. What just happened there?
Ian, sorry, can I ask you a question, please?
Yes. Oh, is that the end of it? Have we been through all of it already? Wow. Yeah.
Can you go to the initial X-ray of this patient?
Back to that one.
Yes. Does the patient have a scaphoid fracture or not? Or I'm just overlooking there?
No, the patient did not have a scaphoid fracture.
Okay.
If you look, so you got to be careful with projectional views of scaphoids, particularly in the flexed and you can often, because of the dorsal ridge, it can look like it's fractured.
Oh, I see. Okay.
Yeah. It's an important question to ask. It's not often that you get combined distal radius and other carpal, intracarpal fractures, but it can happen. And must be looked at. Okay, guys, any last questions?
Hey, Ian, it's Groenies, the original speaking.
Groenies.
Ian, I wanna just ask you something quickly, and I think it's something that we've probably all dealt with while being on call in the state sector at Koller Distal. You end up with casualty officers trying to reduce distal radius fractures through the spectrum, different ones, and they don't always do the molding properly and don't always get the position. So 2 hours down the line, you sit with an unhappy patient that's still slightly drugged with a wet cast on that we all know is difficult to remove, and you having to repeat giving the patient a sedation and molding it properly. So I want to just ask you, that's a headache that we all have, but unfortunately have to deal with, because if you do start doing it beforehand, you're basically causing a snowball and not teaching the casualty officers to reduce it. If you're going to start doing all this yourself, it's almost similar to what we have with ankle fractures. But I want to ask you, if you say in private, because I suppose all of us at one stage will end up in that realm, if your management is guided by the EC officer tonight in Christian Barnard, who might have never reduced the fracture, he's post-comserve and doing a local there, and like, I understand what you say, that's a mission for you to go there and reduce it again, then you'll probably end up operating on all these fractures, even though you know it's not what the literature is currently saying. So yeah, I just want your thought on that as well.
Groenies, that's a can of worms, but you're 100% right. So coming back to patient factors, fracture characteristics, and surgeon characteristics, that algorithm is exactly what plays out in private all the time. The casualty officer is junior. She phones the consultant orthopedic surgeon at 11 at night and says, I've got this patient, 70-year-old Mrs. Jones. And he says, look, if you're not comfortable pulling it, just stick her in the ward and I'll see her in the morning. And the mere fact of admitting her is sent her down a pathway which usually ends up in a surgical intervention. If you had a competent casualty officer who gave it a proper pull, it would go down potentially, not always, a different algorithm. Another layer of complexity in that is the whole medical aid issue about whether it's admitted from a casualty or gone home and becomes an elective case which requires authorization. But from a purely clinical point of view, coming back to that casualty officer, in other words, and this I've had a question before, in view of all the literature saying these elderly patients don't need perfectly reduced things, what do we do when the casualty officer gets hold of that piece of information and stops reducing distal radius fractures? Do we just accept it, or do we continue to tell them that's unacceptable and go and redo every single pop? And I think it's quite a difficult area to navigate, because you certainly don't want the inexperienced casualty officer being the one to decide what's adequate and what's inadequate. I think that decision is ours to make, because we are the specialists, we have the literature, we have interpreted it, and we are going to be the ones to follow up that patient. Remember that no casualty officer ever follows up the patient in its entirety. We are the ones that end up owning the patients, and we're the ones that end up having to deal with the complications of it. So ultimately, it's our decision. And I think as a principle, casualty officers should be taught to reduce these fractures adequately. Yes, we know that some of them will be unstable and will collapse. It's more a decision of what to do when they fall back at the 10-day X-ray, rather than what we do in the initial setting. So that, like, for example, the one has the 4 out of 5 LaFontaine criteria, and we know is going to be unstable. We kind of know that at the 2-week, when that patient comes to the clinic, that X-ray is going to look, it's going to have returned to an unacceptable position. That is when you need to make the decision of whether you're going to accept the unacceptable position, or whether you're going to re-pull that, or whether you're going to change the direction and say that this now needs to be plated. So, Chris, to summarize, I think you must keep telling the casualty officers to do it properly and keep teaching them. That decision does not need to be made on the first day in the casualty as to which way to go. The some, it's easy. The high energy smashed ones, that's an easy decision. The ones that have been pulled, they were going to come back to the clinic, and it's that 10-day, 2-week becomes the difficult decision. And you know what it's like. You're sitting in that clinic and you've got one that's borderline, or 10 degrees, 15 degrees. Now, are you really going to go and re-pull it, or are you going to accept it? That's where the guidelines in terms of elderly patients and outcomes becomes very relevant. And I think we probably are trying too hard to make an X-ray look pretty at 10 days, 2 weeks, when we don't need to be doing it. But that decision is ours as orthopedic surgeons. It's not for casualty officers and MOs to make, because otherwise we'll open a can of worms that says no distal raised fractures needs to be managed actively, and we don't want that. That's not the message that we want to send out. Does that answer your question, Chris?
Thanks, Ian.